This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head podcast with Justine Fidelson and with Dr. Dan Bates. Hey, Dan, how are you?
Good. Are you actually recording? Looks like you are. There you go.
I am. Yeah. We're on. We're on the clock because we only got half an hour today, so we're gonna run through this.
Yeah, do some kid stuff.
Do some parenting. He's got to pick up one of the offspring. Yeah, you can't leave him there.
We're tag teaming and splitting them up today. So
divide and conquer.
It's
almost like managing pain. Oh my God. Maybe we should answer that question first. All right. So Q&As. We're going to run through a couple of little Ask Us Anything questions that you guys have submitted. And we will start with, how do you treat central sensitization? So we've obviously talked about this in other episodes. We have full episodes you can reference, but we'll just give an abbreviated run through 1, 2, 3.
I'll give you my current version / thoughts and
ever-changing,
and you can throw in your versions. So I start with doing a central sensitization inventory. So that's a scale. You can download it off the internet and
or our
you
website.
Can fill it out and add it up for yourself. When you add it up, you can split it. So below 30 is subclinical, 30 to 39 is mild, 40 to 49 is moderate, 50 to 59 is severe, and then over 60 is extreme. And so that sort of gives you categorization. So as we've said before, central sensitization is probably a neuroinflammatory process mixed with some neurological changes that causes amplification of, everything. So then my question is, what's driving the neuroinflammation? As a quick recap, there's 8 buckets that we think about central sensitization in. So first bucket is sensory hypersensitivity. So you get hypersensitive to pain. When it's widespread, we label you with fibromyalgia. When it's focal, we label you with regional pain disorders like temporomandibular joint pain. And then you get hypersensitive to light, sound, smell, touch, taste, heat, cold, food intolerances, balance issues. Most people pick up a diagnosis of autism spectrum disorder once you sort of put them all together. When the sleep part of the brain's involved, you then get sleep disturbance. So can't get to sleep, get back to sleep, or stay asleep. When the area of your brain that's associated with thinking is involved, so you then have trouble with concentrating, memory, and thinking. So you've got brain fog. In that setting, a lot of people also get the diagnosis of ADHD. When the emotional component of your brain's involved, that gives you anxiety and depression. When your brainstem is involved, so when your brainstem is involved, that controls all your organs. So that's where all your dysautonomias come from. So then you've got abnormal sweating, lightheadedness and dizziness when you stand up. So that's when we're getting into our orthostatic intolerance and POTS diagnosis. You get GOT symptoms, so bloating, nausea, vomiting, diarrhea, constipation. So we're into IBS town. Bladder symptoms, urinary frequency, urgency, incomplete emptying. So now we're into diagnoses such as interstitial cystitis, bladder pain syndrome, etc. When the motor system, so the part of your brain that controls your arms and legs, is involved, then you get symptoms such as restless leg syndrome, cramping, tremor, myoclonic jerks, so that jerk that you get just before you go to sleep, when you start getting them throughout the day, and then non-epileptic seizures when things are really unhappy. And then the last piece is when the part of your brain that controls fatigue is involved, you pick up a chronic fatigue syndrome diagnosis. And you'll find that, like, when you look at these disease processes, they have very similar symptoms. So POTS, chronic fatigue syndrome, fibromyalgia, etc. They all have, and they get grouped into this overlapping disease group. So
how weird that we're all developing the same A, B, C, D diagnoses.
Yeah.
Because Dan just listed a bunch.
Yeah. So instead of seeing it that way, we see it slightly differently. We see it as central sensitization is a group of disorders that is the presentation of central nervous system dysfunction. And that is probably driven, I say probably because it's certainly not always the case, by a neuroinflammatory process. So the question then is getting to what the question is here is, which is, how do you treat that? So the question is, what's driving the neuroinflammatory process? So that's where I start. I start looking for what our 10 main causes. So 10 main causes are a persistent injury that's either undiagnosed or incompletely treated. And then you've got inflammatory disorders. So inflammatory disorders in the rheumatoid arthritis, your spondyloarthritis, your psoriatic arthritis, you pick any of the itises. They all sort of go in there.
Pickinitis, enneitis.
Yep. Diabetes and pre-diabetes plays an important role. Hyperthyroidism, celiac disease, pre-existing anxiety and depression. So not the anxiety and depression you get afterwards, after you've got your chronic pain, because if you don't get a bit anxious and you don't get a bit depressed, you're not normal. Then hypermobility.
Yeah. Other pathologies
and obesity are the main ones. And then sitting underneath that are some metabolic abnormalities. So this is where you get a situation where you're getting a stacking effect or a dose response. So low omega-3s, low vitamin Ds, high homocysteines, plus low vitamin B12. Those are sort of the main ones that I look for at the moment because they're diagnosable and treatable. And I suppose the direct answer to the question is I look for those things.
Yeah, the things on the left, the things that are driving
I look
for
the
the
things
neuroinflammation.
that are driving the neuroinflammatory process, and then I specifically treat those. So if you've got symptoms consistent with an autoimmune disorder, I'll pack you off to my friendly neighborhood rheumatologist. Shout out to Scott.
Right. So either treat or refer for the underlying coexisting stuff.
So and I'll test for abnormalities in like blood disorders, like the omega-3 index, etc. And I'll then, if it's low, treat that, and then away we go. So that's really where I start. I think there's a question about MCAS in today as well, and so that I look for MCAS symptoms.
Right,
so that's kind of where I start, and it's about, and within that, inevitably, there's multiple things that are driving it, and so I will then go with what I think is the most important to start off with.
Right. Yeah. So prioritize the most impactful. So Dan does a lot of the stuff on the left, driving the neuroinflammation. I deal with a lot of the stuff on the right that are either amplifiers and or consequences then of the neuroinflammation and all of that accumulating long term, right? So that's where the different conservative pain management strategies come in around lifestyle, which is boring sounding, but very important in this context. Your sleep.
Before we go to Tibia, I just want to let's just define the consequences, because I think the consequences are important because this is where everybody gets caught. Sure. So the consequences of the neuroinflammatory process and your widespread neuroinflammation that's taking place is then that's when you get all your diagnoses, your fibros, your sleep disturbance, your mood disturbance, your cognitive dysfunction, your dysautonomia. So then everyone's getting stuck down, focusing on treating their POTS, treating their thing. And this is sort of, it's the POTS, the sleep disturbance, the mood disturbance, the fatigue that everyone is focused on treating, where I'm treating the stuff that I kind of see as driving it. But it's really important to treat those consequences because they have a positive feedback loop in the system. So they just make everything worse. So if you don't treat them, it doesn't help. Right. But don't get stuck treating them.
Right. That can't be all you treat because there's a ceiling to that and you can only get so far with that. But if all those things are out of control, does not give you a good shot with the other things in your capacity, right? We've talked about this in the pacing episode. When you're working with very little and you're constantly bubbling over, it amplifies and makes all the symptoms much worse. So you have to get your protein in your diet under control. You have to look at your calories and macros. You have to look at your recovery and pacing and energy management, right? You have to look at movement and improving some of those compensations and inhibitions and weakness spasm cycles that are keeping you in patterns that are also adding to the total output of pain. You have to be able to downregulate and destim and distract and use things like mindfulness and breathing, to filter out pain. It's not to cure it, it's to manage it. And so those things, when you have a lot of sensitization or have had sensitization long term, have a disproportionate effect positively compared to someone who just has focal body part pain. And you don't want to have terrible sleep and these other things, but you have more capacity. So the consequences and how far over your pain threshold are different than in the context of things like sensitization or with CRPS alongside or on top of that. Yeah.
So how are you going to manage the patient that's presenting with orthostatic intolerance or POTS? So what's that little bit look like?
From a movement perspective, it's working with positions that are going to work for you. So standing exercises are often hard for patients like that, right? So how do you then work on stability in other contexts, increasing hydration, increasing salt? If you have that kind of POTSy, part to that also. This is obviously not my bucket, but controlling heart rate with things like propranolol, like Dan, do you do that much with orthostatic intolerance if it's just high heart rate?
No, look, I do the basics. So I start everybody with, increase your fluid intake to 2.5 to 3 liters per day, 10 grams of salt, which sounds like tons, but it's only 2 teaspoons.
Right. It's actually not that much. A lot of people are getting that much and don't think they are.
And compression garments. The compression garments I'm recommending at the moment are Supercore, which are a Melbourne company. Hello, guys. Yep. Feel free to come and sponsor us.
And I've actually wear those too. Dan prescribes them.
Oh, Jazz is wearing it too. Yeah, they're really good. So I'm starting that, and I will refer off to a colleague to then manage, the medication side of things. So that's where you've got, so propranolol for true prots, and then, fludrocortisone, midodrine, ibuprofen, and then getting into some more specific stuff, which I tend to engage a colleague for. I don't prescribe those.
Yeah. And each one of those buckets that Dan basically went through have sort of a first, second, third line or biggest dial mover, habits that you want to impact first. So if you're trying to improve sleep, fix your anchoring around sleep wake time and cut out of control napping, for example. With nutrition, it's really easy to look at where your calories are coming in, adjust that, and bring protein up if you're low and you have HEDS. So what things under each domain have the biggest impact on your symptoms? If you're someone who has out of control anxiety and depression, manage that. If you're not someone who has out of control anxiety and depression, focusing on that a ton is not going to move the needle as much for you. So that's kind of from the left side and the right side.
The other way to choose where you start, there's some interesting data within the autism spectrum disorder literature that shows that people who have a diagnosis of ASD are more likely to have increased sensitization if they have light sensitivity and anxiety. And it looks like light sensitivity and anxiety then are these key symptoms that drive further sensitization. So if you're in a position where you're like, I got all of this stuff, which a lot of people do, like a lot of people just got like the whole lot of it.
Yeah. And once you got over 4 or 5 buckets, it's a lot.
Yeah, it's a lot. So where do you start? I think that a lot of time, I think you can start with light sensitivity. So you do that.
It's an easy one. Throw the glasses on.
So FL41 tinted glasses are a good start. The other company that is around that's got decent data, it's within the migraine area, but nonetheless, it still works in the same way, is Avulux. By chance, are actually a Melbourne company once again, but that's just a fluke. They have a set of glasses that filter out light and decrease light sensitivity. So they're particularly good for headaches. So have a look at those. The FL41 glasses you can get on Amazon, and they're pretty cheap. Yeah. The other thing there is, and then treating your anxiety. If you're like, where do I start? Well, start with treating the anxiety, start with treating your
and if it's harder to identify specific things, then go with those more global sensitizers, right, that are all over. And then you can hopefully do a better job identifying some of the more specific underlying, like intolerances or physical drivers. So from the left and right.
That's a start.
Perfect. All right. Next question. Questions to ask when looking for members of your care team. So this is a good one because we just came out with an episode on the spectrum of care. And we also did an episode on owning your care, right? And as a patient, how you kind of can look at it as you are the boss of your care team. You need to have like a energetic and sort of mental connection with the person, trust them, believe in the way that they are approaching pain, and have them offer things that either add to what you've already done or have access to, or help you better understand how you can approach that. So everyone's going to have their different biases and preferences and reasons for how they approach pain. And the goal is to have that match up with the type of pain and the presentations those treatments and modalities are most effective for, which Dan did a really good job splitting apart in a cool way. So I'll let him kind of take from here around bias and what works best with.
We originally split it into left wing, right wing, and then centrist, because it's kind of the way my brain was thinking at that point in time. I think that a better analogy or a better language is interventionalist, so which is kind of right side. Right. Left side is conservative or essentially non-interventionalist. And then in between, I don't have a word for us, kind of like...
It's a mix. Until we have a better word.
Until we have a better word, guys that do everything. So I think what you need to recognize, look at what you're experiencing with your pain. So if you have chronic pain, if that chronic pain is focal, if it is like it's focal, it's an intrusive pain, and particularly if it's intermittent, is it's focal, intermittent, and proportional. So little injury, little pain, big injury, big pain.
It might still hurt a lot, but it
still hurts a lot,
right?
Still intrusive, still makes life crap. But if that's how it's kind of presenting, or it's in like just one nerve root distribution, like I was saying the other day, I had a patient turn up who had a central sensitization inventory score of 10, which is like not sensitive. I like, oh my God, I love you. And came in with an MRI that matched his presentation. I was like, duh!
Yeah, exactly.
So good.
Amazing.
So in that, great. You need an interventionist.
Right side.
So you need to go to that right wing interventionalist that can go, yeah, great, I can deal with this for you.
And another way to look at it too is, do you not have any of those buckets we just went through? Or maybe just one or two max. You're not highly sensitized as well, where you got to look at all the other stuff we just rattled off as much.
Yeah. Let's go to the other side. So if you do your little central sensitization inventory score and you are over 60, I'll tell you now that
not a gold star.
If somebody does an intervention, like an injection, what's going to happen is you blow up in a big ball of pain afterwards, most commonly. The reason why people blow up in a big ball of pain is not because of the procedure itself, but just the use of the needle. You know, your nervous system's hypersensitive, you explode in a big ball of pain and...
Right. I mean, think about it. When even leaning against your own body weight in a chair is... stabbing multiple needles in there is also going to cause a disproportionate response. And that's
so what you need to do is go down the track. Now, if you're under 60, I think that, you know, then you're in there, you need to find somebody that's a new. If you're over 60, I think you need to find somebody that's going to help you with those side of things. And it's going to take you through all those strategies to, number one, identify what's driving the sensitization. Number two, treat the consequences of the sensitization, turn off your and then aim to sort of decrease it. So within that setting, you may be also looking to decrease how large the area of pain. So let's say you've got a big area of pain, you want to shrink that shrink that down. So there's certain medications like amitriptyline, duloxetine, shrink things down in size. Interestingly, I think with directly treating the neuroinflammatory process, low dose naltrexone, what it does, the little cells within the brain that become inflammatory are called microglia. And so low dose naltrexone is a microglia stabilizer and it polarizes them towards anti-inflammatory. So that's how it's probably how it's having at least a part of its effect. It's not all of its effect.
So it pushes things a little bit in the right direction more so than it being in the wrong direction.
Yeah. And so the other things within that as well, the other sort of medications in that area is palmitoyl ethanolamide, also known as PA, and then luteolin. So there's been a number of randomized control trials done by the Italians looking at a combination of PEA and luteolin in long COVID. And so long COVID is another central sensitization disorder. The trigger, the thing that's driving the neuroinflammatory process in that setting is the COVID or the immune response post-COVID, but it presents as central nervous system dysfunction, which is why it's got all its overlaps with
which why all those long COVID patients
and dysautonomia syndrome. Yeah.
And those are available subs, right, Dan?
Yeah.
So
you can get them. And their data's pretty good, actually. So they've done a solid job with some big studies that show that it's effective. So if you identify your pain as, okay, this is widespread, it's disproportional,
I have these other buckets.
I have all these other buckets going on. Okay, you've got to go to your conservative therapist that's going to take you through managing all that side of things.
And that might include referrals to psych, to specific modalities and ways of looking at it, because one clinician can't necessarily even do all the conservative pieces.
Oh, absolutely. So and it's being able to identify that part of my driver is my anxiety. Part of my driver is my depression. I was going to treat
or lack of movement,
Yeah. Or part of my driver is that I'm deconditioned, which is really tough for the chronic fatigue patients. Like you've got heaps of pain, seriously fatigued, can't get out of bed, stay in bed 23 hours a day, get increasingly deconditioned. It's like this terrible cycle. Like having someone assist to break that cycle is really, really important.
And then if you're a mix of both,
if you're a mix,
if you're a mutt like me, like many of us,
if you're a mix, I think what you need is that you've got to do one of two things. You either get some conservative guys, some interventional
and
guys
an interventionist
that hopefully understand each other's roles.
Right.
And you then go, okay, this is where I'm at the moment.
And again, you're the boss. You're the in-between.
Yeah. And you would start, and the approach that you would start with is get your sensitization under control,
right.
Get those numbers down and just shrink it down. So I think I use essential sensitization inventory to track patients along these lines. If they're over 60, I just start with treating the sensitization. If I can get, it's interesting. If you come down by 10 points, patients will say to me, I just feel better.
Yeah. Get out of some of that stuff.
But it's about a 10-point improvement in a CSI. Like just anecdotally, that's what I find. So if you can get people down into low 50s, low 40s, and we've gone from really big pain to now more focal pain, okay, that's now where you need your interventional guy.
Yeah. And then you'll have more success.
Going to go find what's the underlying driver. And you will tend not to blow up when they use the diagnostic block to look for it. And I think, that in itself, as a sign, when I'm talking to people and I'm consenting them for a procedure, one of the things is like, this may make you worse, but that tells us something. Yeah. Okay. So that's not, it's very unlikely that that's going to be a complication of the procedure, because we do the same procedure
over and over
on thousands of people. Yeah. That is going to be the patient's nervous system is super sensitive.
Right.
I put in a needle, they blow up in a big ball of pain. Okay. I need to then treat the hypersensitivity, not go looking for what's underneath it at the moment, because you're not going to find it.
Well, and even from an assessment perspective, when you're trying to gather history, it's harder to tease apart when there's so many other pieces and intense pieces that the patient too is expressing and going through, from a diagnosis perspective.
Oh God! And if they've got brain fog, and this is the thing that's so difficult. They've got brain fog, so patients can't remember what happened last week. Yeah. They're concentrating to answer my question because I don't actually remember. What did you just ask me?
Or the story has become so big, because it is a really big story.
And overlapping.
And then Dan has to cut you off politely. Like, it's done with me on an episode on air. If he'll do that with me on an episode, he'll do it in the consult.
Oh, yeah. Sorry. So I just apologize now if I cut you off, because I probably got the piece of information I needed.
It's just trying to do his job. All right. I think that was a pretty good overview, right? So seek out clinicians who have the skill set to help you with your different pieces of pain and take ownership over the pieces that you as a patient need to get the most out of the procedure, the medication, etc.
And you're the employer. If you don't like them, sack them. Move on.
Right. That's it. Yeah. All right. Last but not least, in a completely different random direction, footwear. This is one of my people's questions. Shoes to wear and avoid. Obviously, this depends a lot on what, pain pathology or the situation we're talking about. From my perspective, when it's something like CRPS, complex regional pain syndrome, right, you often have extreme sensitivity and allodynia, whether it's foot, hand, wherever it is on your body. This question would pertain to the feet. Obviously, neuropathic pain in and of itself that is not CRPS causes the same sort of issues to a degree. So it can be nice to find shoes that are a little bit looser, wider, not heavy with a ton of fabric that feel like a foot coffin, just kind of like adding this annoying I almost said foot sarcophagus because of the last episode when I did it. But it's like this pressure, tight, enclosed, aggravating feeling. Whereas if you just have a little bit more space to breathe, that can just take a tiny bit of that edge off. I would wear flip-flops a lot in the earlier years of CRPS. The downside to that is it creates a lot of sort of toe scrunching, and you don't move as much at the MTP joint of your foot when you step. So it can kind of have some negative effects gait-wise long-term, but for here or there, just find ways to, have your feet free when you can. Get ones that have straps instead of like the little between toe wedge. When it comes to a gym or walking context, heels. One of my friends, shout out the Neuro Studio in Mariska, she has MS as well as CRPS in one of her feet, and heels help her, not like dress heels, but shoes with flat shoes with a little bit of a heel help with gait, because it gives you a little bit more dorsiflexion, which can also help in gym settings. That's why Olympic weightlifting shoes have an actual bigger wedge in the heel. So to get a little bit more movement where you don't have it, that can be a way around. And then another interesting point is around orthotics, to orthotic or not to orthotic. And this conversation is a little bit like the one around bracing, where it depends and it's a dose response thing. And if you wear them all the time endlessly and do no foot strengthening, maybe not the best, but you also shouldn't be completely anti-orthotic, because they do put your foot in a better position to, again, have things work as they should at the chain. So Dan has some orthotics thoughts too. I feel like
I do. The orthotic thing, I think, is I think I've got to take a step back from that. What I'd like to everybody to do, I've got a little bit of a little visual thing for people to get the idea. If you just grab your thumb and your index finger, just overlap it into overlap there, and you create a little sort of rectangle,
a little peephole.
Yeah, a little peephole. Okay. Yep. So if you think about that, and then what you do is think about your weight minus 5 kilograms, make yourself feel a little bit better. Now double it. And every time you take a step, twice your body weight goes through that little area.
Little ankle bone.
That little area, twice your body weight. And so that takes place because of a whole bunch of fancy physics, which is called ground reaction force. And so the amount of load going through like a tiny area is enormous. Now, if you times that so there's advantages there and disadvantages. Firstly, the advantage is that if you're looking to lose weight to decrease load, you only have to lose a very small amount of weight to decrease an enormous amount of load. So the math works like this. If you lose 500 grams, let's go a pound for the Americans. Like the non-metric part of the world.
Ethnocentric part of the world.
So if you lose 500 grams, so half a kilogram, that's 1 kilogram per step. If you take 5,000 steps a day, which is pretty, it's on the mid to low range.
Oh, Dan, I'm offended. That's about yourself.
10,000. That's 10 tons of load with just decreasing half a kilogram in weight. So you can get enormous decreases in load with just small amounts of decrease in weight. The other thing that's important to recognize is that if people are looking to go back to jogging and something along those lines, every time you take a step, just walking, it's 2 times your body weight. When you run, it's 5 times your body weight. So everyone goes, oh yeah, I was walking and then I started running and then I got sore. That's because
it's crazy.
You put up the load, you doubled the load. I was walking 5K, I started to run 5Ks. Okay, well, you double, you 2.5 times the load going through your lower limbs. So that's
you overdid what you had the endurance and strength.
And when you jump, it's 8 times your body weight goes through your legs. So the forces are enormous. And so, that's when shoes and surfaces become really, really important. Right. So my take on shoes are, if you've got a shoe that you've been wearing and you need to get a new one, buy the same shoe. Just buy the same shoe. You can
update the colors. You can get a newer style.
Get the crappy new color. Just look at this. Look at the kid that's selling it to you and say, dude, just get me the least crappy color in exactly the same shoe. Yeah, but this one is more. No, dude. No, same shoe, least crappy color. That is the way that you should buy shoes. And so because it's changing shoes that then alters your mechanics slightly. And that's when all of a sudden, because of these ground reaction forces and the amount of load that goes through.
Now your hip or your back. Higher up.
So with regards to orthotics do definitely have a role with the biomechanics of all this. If, it starts at your bum strength. So if your bum kicks out, if your bum can't hold you up, then your knee falls in.
Yep, the valgus.
Your midfoot drops. That then loads everything. You've got to hold. Then
that was me the last 4 years.
Yeah. So you got to work at strength in your knee, strength in your quads, strength in your calf. And so getting some mid-foot support while you develop that stuff to allow you to
do more,
to work and do that stuff, very important. When I was 10, got put into orthotics and never taken out. And so now I can't get rid of them. I'm in orthotics forever.
Part of them, yeah.
And which, whatever. It is what it is. Though. But you do want to be able to look at them as a short-term thing. Things like heel wedges, being able to sort of improve people's liners, heel cups where you can get some more padding through it, metatarsal domes for particularly those with Morton's neuroma, all really, really good and really simple ways of offloading different parts of your feet. Right. And feet are hard, really, really, really hard. Hats off to the podiatrists. They just the physics of it is so difficult. They do a really good job just making some change.
Yeah. And the last piece I kind of add around footwear and orthotics and things like that are insoles around from the perspective of increasing sensory input from the ground, because a lot of us, whether it's neuropathy or whatever you have as far as type of pain, particular neuropathy, CRPS, you can either have extreme intense sensation or lose sensation on parts of your foot, top or bottom. You gotta go. Okay. So if you have a less sensation on the bottom, it's my turn. Hold on one sec. Then adding an insole in there that has a bit of texture can help that hip respond to the floor better. So look at that if you're someone who's like, I don't feel anything on the bottom of my feet.
My 15-year-old's going to be texting me in like 30
it's my
seconds.
Fault. Blame me. All right. Anyway. We're good. We're done. Thanks, guys, for listening to this. Hope you found some pieces helpful, and we will see you next time on It's Not In Your Head podcast. Take care.
Sorry for being late, Mads. I'm coming now.
It was my fault, Maddie. Bye.
Bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.